So next we have Dr. Anabi talking on Beyond the Surface, Understanding Posterior Scleritis. Dr. Anabi is a Senior Consultant, Anti-Segment and Uvea Services at Dr. Tony Fernandez Eye Hospital. Over to you, Dr. Anabi.
So from anterior, let's move on to the posterior segment. My topic is understanding posterior scleritis. Posterior scleritis is an inflammatory disease that involves the sclera posterior to the ora serrata. It is one of the most underdiagnosed ocular conditions. It forms about 6 to 20% of the patients with scleritis. It is usually unilateral but can be bilateral also with a female preponderance. There are two types, diffuse, which is most common, and second is a nodular. 30 to 50% will have a systemic association. The most common clinical presentation is periocular pain and headache, typically worse at night and waking the patient from sleep early in the morning. Then there will be pain on ocular movement, proptosis, and blurred vision. Let's see this case. This is a 19-year-old female complaining of pain and redness of 10 days duration. She was in Bangalore at that time, consulted with a doctor, and she was diagnosed as migraine. With no relief in pain, she consulted again and she was given some other treatment and no relief. She came to us with defective vision of 2 days duration. At presentation, her vision was 624 in the right eye and left eye was 66. Anterior segment showed conjunctival congestion and fundus showed exudative detachment in both the eyes. So we did an OCT which showed neurosensory detachment in both the eyes. So this is a case of bilateral exudative detachment in a 19-year-old female. So what is the diagnosis? We were a little bit puzzled by the presentation. We did a B scan and it showed increased posterior scleral wall thickness, subtunian fluid collection resulting in a T sign, and FFA was done to rule out any other cause which didn't show any specific findings. So she was treated with systemic steroids and it was continued for 3 to 4 months, but it was recurring whenever we were trying to reduce the dose. And she was rheumatology consultation was done, investigations were all negative, and she was started on methotrexate, which was continued for almost 2 years. Now she is doing well. So coming to the differential diagnosis of exudative RD, it can be VKH, CSR, and in nodular posterior scleritis, it can be a melanotic melanoma. So how do you differentiate VKH? It is a bilateral disease. It is associated with vitritis. There will be pain and photophobia. Fundus will show again exudative detachment in both the eyes. But FA will show multiple pinpoint regions of leakage at RPE level and disc hyperfluorescence. And OCT is very much diagnostic. It shows serous RD with typical fibrinous septa. Coming to CSR, it can be unilateral or bilateral. It shows a dome-shaped elevation of the macular region. OCT shows SRF and RP detachment, and FFA is diagnostic. It can be either a smokestack appearance or an ink blot pattern. In nodular scleritis, we have to think about choroidal malignancies also. In choroidal melanoma, it can be unilateral, pigmented or amelanotic elevated choroidal mass. Lipofuscin may be present. Serous RD and or sentinel vessels are possible. B-scan will show dome-shaped or mushroom-shaped choroidal lesion with typical low to medium internal reflectivity. OCT will show dome-shaped solid choroidal mass accompanying SRF is also possible. This is my case number 2. This 38-year-old male presented with pain, redness and blurring of vision of 2 days duration. He had sudden blurring of vision and it was counting fingers 2 meters, but he was improving to 6.6 with minus 3.25 diopter and in left eye it was 6.6. In right eye, the IOP was elevated, it was 32 and left eye was normal. So anterior segment evaluation showed conjunctival congestion and chemosis, and AC depth was shallow and gonio showed 360 degree appositional closure. So this is a secondary angle closure without pupillary block. Retina showed retinal folds. B-scan showed choroidal thickening and T sign. So posterior scleritis can present as secondary angle closure without pupillary block. She was also treated with systemic steroids without any recurrence. Investigations were all negative. So intraocular pressure may be elevated in scleritis, the causes being rotation of the ciliary body and iris root into the angle closing, causing angle closure without pupillary block, blockage of the outflow tract due to inflammation, elevated episcleral venous pressure, peripheral anterior synechiae or neovascularization. There are certain associated features. it can be associated with anterior scleritis. It can come as shallow anterior chamber. There will be choroidal folds, retinal folds, exudative RD, disc edema. Sometimes inflammation can spread to the vessels and can cause CRVO, BRAO. It can present as annular choroidal detachment, neuroretinitis, RPE RIP, and it can present as a choroidal mass also. So multimodal imaging is used to differentiate all this. B-scan, FFA, ICG, OCT, MRI and CT scan. Ultrasonography is considered the most helpful in the diagnosis of posterior scleritis. There will be increased posterior scleral wall thickness, subtenon fluid collection resulting in a T site, exudative detachment, presence of scleral nodules and annular choroidal detachments. But the T sign is not pathognomonic and can be seen up to 41% of the patients with posterior scleritis. FA shows early pinpoint leaks with late pooling of the dye in patients with SRF secondary to posterior scleritis, but this pattern is not specific for posterior scleritis. Disc leakage and vascular staining may be present. Choroidal folds which may appear as alternating light and dark bands on FFA. ICG shows diffuse zonal choroidal hyperfluorescence reflecting vascular hyperpermeability in the choroid, fluorescing pinpoints in the zonal hyperfluorescent areas, choroidal perfusion delay, enlargement of the draining choroidal vessels. OCT helps in evaluation of the adjacent choroid and retina during the course of posterior scleritis. It shows neurosensory detachment. EDI OCT measures the choroidal thickness, and thickening of choroid occurs in posterior scleritis. So coming to the etiology, it can be infective or non-infective. Infective being tuberculosis, syphilis, herpes zoster and herpes simplex. In the non-infective variety, rheumatoid arthritis remains the most common cause. What are the tests do you do to find out the cause? It has already been dealt in by the previous speaker still. Manto and quantiferon TB gold test and chest x-ray to rule out tuberculosis. VDRL and FTABS for syphilis. Rheumatoid factor, anti-CCP for rheumatoid arthritis. ANA, anti-dsDNA for SLE. And to rule out sarcoidosis, ACE, chest x-ray and contrast enhanced CT is done. For GPA and PAN, ANCA is done. And for ankylosing spondylitis, HLA-B27. Treatment, oral steroids remain the mainstay of short-term management of scleral inflammation. Pulse intravenous corticosteroid therapy is given whenever you need a rapid control of inflammation and in vision-threatening emergencies. Indications for immunosuppressives when there is inadequate response or failure to respond to oral steroids. Recurrence of scleritis on a dose of more than 7.5 to 10 milligram per day of oral corticosteroid and serious side effects with corticosteroid therapy. Methotrexate is the most selected first choice. Then comes MMF or mycophenolate. Azathioprine is useful in scleritis associated with relapse in polychondritis and cyclophosphamide in patients with systemic vasculitis. Biologics comes as the third line of management. Adalimumab, infliximab, tocilizumab, rituximab and tofasitamab. Next speaker will be talking in detail about the biologics, so I am not going to the details. Thank you.
Thank you, Dr. Anabi, for that informative and lucid talk.